أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear friends and fellows and students, and specific students which are interested to learn and want to gain some knowledge, although they are very, very thin in number, they are not interested. They are dependent upon the reporting of the radiologists. I will again point out that the radiologists are sitting in their rooms. They have not actually taken the history of clinical examination, and they have not assessed the differential diagnosis depending on the presentation. You have to read the X-ray yourself, and that will become more important and more informative than the reporting of a radiologist, specifically speaking the plain radiology. The reporting the X-ray chest number 11, a case which I have seen about 12 years back, a 52 years old type 2 diabetes mellitus who was on hemodialysis for chronic renal failure. It is a diabetic nephropathy and leading to the chronic renal failure, and he was put on hemodialysis twice a week, developed sudden shortness of the breath and heaviness in the chest in a very few minutes to an hour. He was admitted in the emergency and accident department of the coronary unit in Civil Hospital, Karachi, for the acute coronary syndrome actually, because the presentation was he was sweating and he was in shock type of state, and there is a heaviness, putting his one palm on his chest, etc., signified that he was a patient of definitely of acute coronary syndrome. But after exclusion, referred to us, means internal medicine for the management. It was actually in the night time what has been done. In our unit, the patient was severe shortness of the breath, very severe shortness of the breath, and his respiratory distress, actually I would say, with the central cyanosis under the tongue and buccal mucosa were grayish blue. Pulse was 100 per minute, is low volume pulse, and it is the pulse which I will say that it is irregularly irregular. Although the BP was 80/46, he was hypotensive, and pulsus paradoxus or doxosis was present. What it means that if we will take the systolic blood pressure as routine, and then we'll take the blood pressure curve at the same place in deep inspiration. Usually there will be a drop of about 2 to 5 millimeter in some persons, and most of the persons 2 millimeter, in some persons 5 millimeter. It is called Mary's reflex. It will be exaggerated in this case. It is known as pulsus paradoxus. So the difference between the routine in systolic blood pressure and in deeply inspired blood pressure was more than 10 millimeter. Difference was there. So this is called pulsus paradoxus. The respiratory rate was 44 per minute. Definitely tachypneic. To me it was hyperapneic also. The heart sounds were inaudible. we cannot, detect any heart sound. Very, very feeble. The jugular venous pressure was touching to the mustard process, although I have not measured it. But it is touching the mustard process. And I cannot make the characteristics of the jugular venous pulse, A wave and C wave, etc. I don't see any, C wave in it. It is up and down. There is no notching. So JVP was touching to the mustard process, and the SpO2 by pulse oximetry was 80%. 80% at that time. Means, actually it was lower down, and he was compensating in any way. In our unit at that time, the echocardiographer, who was actually internist also, he was at home and he was called upon on urgent basis. And he said, I am coming. And X-ray chest immediately taken and presented to you for reporting. It was a dry film which was given to us. This was the position. Now reporting this X-ray chest number 11. What you see, the requirements has been done, and it was difficult in this case. So the patient was in respiratory distress. But see the parameters. If you want to take correct parameter, you have to, do this X-ray in a standing position so that everything will be clear. So it is a PA view because the vertebral spine is not seen and intervertebral space is not visualized here in this lower part of the middle mediastinum. Supraclavicular foci are wide enough here. Wide enough. So it is PA view, dominant frontal projection. And then we will go for the S, means he was standing. I say that is he was standing. 1, 2nd, 3rd, 4th, 5th, 6th, 7th. Although he was in respiratory distress. Very interesting position. Now the second thing comes into mind afterwards is that he was straight, you see, S plus S. One line drawn here, spinous process, one line drawn at the sternoclavicular joint. 90 degree here, 90 degree here. And thirdly, he was still deeply inspired and hold the breath properly or a difficult one. But he had done it. What see here is you can see the bronchovascular markings are coming here and here and here. So it was not expiratory film, it is inspiratory film. Then the bony skeleton here, the clavicles, they are normal, the vertebral process, spines are normal, intervertebral spaces, spinous processes clear. Shoulder joint, and we not visualize the scapularis lateral border or medial border, rather is outside the thoracic cavity. It was a good film which was taken. Now counting the rib, the first rib, the second rib, the third rib, the fourth rib, the fifth rib, the sixth rib, upper border, lower border, upper border, lower border, should be counted out. And soft tissue around here, lateral thoracic wall, below the dome of the diaphragm, the supraclavicular foci and the side of the neck, they are all normal, nothing significant is seen as soft tissue shadows. Trachea is here in front of you. This is the tracheal aerograms. They are central. They are not displaced. Slightly towards the 10 degree towards the right side, which is normal. Still the queries are how much the patient is severe respiratory distress, GBP was raised and everything is in front of you. Then everything is now up to normal. Now the lung field is surrounded. They are divided by, for the sake of the study, the second one line is drawn, and second line is drawn at the first line at the costal cartilage, and of the costal cartilage here, it is the horizontal line, and the fourth rib or horizontal line, imaginary line. So lung fields are divided into upper, lower, and the middle right side, upper, middle, and the lower left side. Two components should be visualized as normal. One aerograms and second is the bronchovascular markings. They are present. Or the slight haziness are seen here. Slight, not much. Costophrenic angle, they are hazy on both sides, no problem. Overall, the imagination is concerned, that is, I was expecting much changes in the lung fields. The lung fields are now nothing significant is seen. And patient in respiratory distress. Patient was in respiratory. Look, these spaces are wide. It is 3.3 centimeters at the mid-clavicle line. Because of the effort he's putting on taking the deep inspiration. Very interesting situation here. The lung fields are normal. Everything is normal up till now. What is abnormal seen is the upper dome of the diaphragm. Here it is flat. Slightly here it is a obstruction. And on this side, the costophrenic hazy, cardiophrenic angle, the cardiophrenic angle. Very near to the costophrenic angle. This one. And now the middle mediastinum is divided into two. For the sake of this border, look this border. It is changing direction here and changing its direction here. So line is put here, imaginary line, to divide the upper part of the middle mediastinum and the lower part of the middle mediastinum. Now the lower part of the middle mediastinum, the size is definitely very, very big. Cardiothoracic ratio is very, very high. Cardiomegaly seems to be cardiomegaly. What is seen is the seen. Now look, there is the border here, slight one border, another border, double border are seen on the right side. On the left side, it is very, very curved border. It's from here, and here the apex which is pointing transversely. If it is cardiomegaly, again there are two borders here. One is here, and again it is above there. On this side there is double border, in this side is a double border. And the apex is transversely placed. Means that if it is cardiomegaly, then it is predominant right-sided cardiomegaly, not left-sided cardiomegaly. The shape is concerned, it is, see, it is a very, very, just like a boot, very big boot, heel, and this is the top, what is seen in this, or a flask-like shape of this lower part of the middle mediastinum. And the upper part of the middle mediastinum, one line is drawn, imaginary, and second line is drawn here. First part, second part, third part, fourth part. This is the first part. This is the ascending aorta. Second and third representing the arch of aorta. The arch of aorta and aortic knuckle is putting here at the upper part of the sternoclavicular joints. Very abnormal position. And then the last part is the fourth one, it is the pulmonary corners which is seen here. Okay, it is not very prominent, it is not putting out, you can't see. So the signs of the pulmonary hypertension even are not seen in the lungs also. And this is very important point, that we have got this type of a problem which has got double border on the left side and double border on the right side. In mitral stenosis there is the double right border, not on the left side. Now last point is that the right and the left highlight shadows are not visible. Here it is not visible, here it is not visible. This is called the hilum or hyla overlying sign. Something is going so much so that the hyla are hidden. Otherwise, the hyla are always present. In most of the cases, there is no silhouette sign here. So, hilum overlay sign is present. It means that hilum overlay sign is present when there is a fluid in the pericardium. There is no other differential diagnosis other than this. Bilateral hyla shadows are masked. Globular heart, double heart border here, double heart border here. So this is the pericardial infusion. And it is causing clinically, what we see is the pulsus paradoxus, the hypotension, central cyanosis, moving towards cardiac tamponade, backstride, shortness of the breath, very severe shortness of the breath, chest heaviness, and respiratory distress. Also going to the respiratory failure, type 2 respiratory failure. Backstride, that is called. If somebody was very, very good in the clinical examination, then he can demonstrate the Ewart sign. Ewart sign is the dullness which will be present at the lower part of the interscapular space because of compression of this sac loaded with the fluid. The heart was compressed there, and there will be dullness present at that area. It is called Ewart sign, interscapular space. It is difficult to demonstrate. Very keen type of the clinical examiner can do it. Today, everybody has forgotten the Ewart sign. At one time, we have demonstrated it. Everything which is written in the clinical methodology, for example, Hutchison, very good book for the clinical examination. In that book, at one time it was regularly published, Ewart sign. Now they have not published afterwards because of the new technology which have been invented. So overall, the conclusion is this: everything in this X-ray, according to the protocol, is normal, except one is there is a cardiomegaly, double heart shadowing on the both sides, globular shaped, flask-like shaped heart with hilum overlying sign. And this is one condition which can cause, and that is the pericardial effusion. There is no other differential diagnosis I can make. Otherwise, you put that some mediastinal mass is occupying. If the mass, then the trachea was shifted and there will be effect on the lungs. Lungs are absolutely clear. There is few conditions in which the lungs are so much clear. For example, pericarditis, chronic constrictive pericarditis, for example, or in the pericardial effusion. There is nothing in the lung. Lung is normal. What is happening is this: there is low ejection fraction, so blood is not going to the distant part of the body. Associated is the irregular pulse, because it will cause the atrial fibrillation or flutter to occur. So this is the very, very interesting X-ray of what is called the pericardial effusion, and the signs I have demonstrated in front of you. The inference is that I will go for the further investigation immediately to confirm my diagnosis. That is, echocardiography will be taken to confirm it. Although I knew that this is pericardial effusion causing the cardiac tamponade. For example, the echocardiographer was not present, or he was not coming on the time because of the distance. then I will judge as the cardiac tamponade has occurred because of the pericardial effusion. I will go for the blind, what is called pericardiosynthesis. Pericardiosynthesis is concerned. So it is the only thing that one can remember, that the pericardial effusion can, if it is causing the cardiac tamponade, should be deal with on an emergency basis, and the blind pericardial synthesis should be done. While the epigastrium, you put a needle in it and you draw it. The patient has to die in any way. You put a needle, white bone needle, and the fluid comes very fast, very, very fast. It was very fast at that time, so much, when the echocardiographer arrived, he put a needle, and the jet of the fluid was about, 1 meter more than this. And at once, or I think in 1 minute, the patient was comfortable. This was not elective pericardial synthesis, this is a blind emergency pericardial synthesis. Afterward, he will do the elective pericardial synthesis, therapeutic pericardial synthesis, etc. That is another type of the pericardial synthesis. You go the therapeutic, and then you go for the investigative type of a pericardial synthesis. The transudate or exudate or whatever, it is another problem. So echocardiography and the immediate tube withdrawal is the answer. Okay, this is the how we deal these patients. Other investigation can be done, lateral view. The other routine investigation should be done in this patient. But I remember that this patient was thankful to the echocardiographer, my friend, who has done this blind therapy. And he was highly thankful to him. And this is called, what we call is the human is so important. And he was ever thankful to him to relieve his symptoms. Otherwise, the patient at the dire side of the emergency. I think I have explained it, and you should appreciate my approach. I'm very thankful to you for the listening of this case and the interpretation of the chest. Inshallah, the next X-ray will be interpreted. There are a few X-rays more to be reported, and we will meet again. We will meet again, inshallah. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.